We're very grateful for the opportunity to present to all of you today on some of the research that we've been doing looking at opioid-related harms among a group of workers who have experienced work-related injuries. So the research that we will be presenting today is the result of a collaboration between the Institute for Work and Health and the Occupational Cancer Research Centre at Ontario Health, which are both based in Toronto. This research was made possible with funding by the Public Health Agency of Canada. And in addition, the Occupational Disease Surveillance System, which lies at the heart of this project, was established with the support of the Ontario Workplace Safety and Insurance Board, the Ministry of Labour, Immigration, Training and Skills Development, and the Ministry of Health. Before we continue, we'd also just like to acknowledge our project advisory committee that has provided guidance to us throughout this project. The committee includes labour and workplace representatives, health and safety associations here in Ontario, public health and substance use experts, and representatives from the Ontario Workplace Safety Insurance Board, which is the workers' compensation system here in Ontario, and the Ontario Ministry of Labour, Immigration, Training and Skills Development. So as I'm sure many of you are aware, North America has been facing an unprecedented public health crisis related to opioid-related poisonings, which has worsened in the last several years. So data from the Public Health Agency of Canada suggests that between January 2016 and September 2024, there were over 50,000 opioid-related deaths among Canadians. The graph on the right-hand side shows the breakdown of deaths by age and sex. In this case, it's in 2024, although the pattern is generally similar year after year. And what you can see there in those dark bars is that males of working age, particularly those between the ages of 30 and 59, have been most affected. And so given these characteristics, there's been increasing interest in understanding whether aspects of occupation and the workplace environment have a role to play in contributing to opioid-related harms. So from a research perspective, most of what we know about the role of occupation in opioid-related harms has come from data in the US. So on the left-hand side here, you'll see some titles that are just from a sample of those studies. But consistently, the data emerging from these studies have clearly shown occupational patterns in opioid-related deaths. So across these studies, opioid-related poisonings have been particularly prominent among those in construction and trades, natural resources, transportation, maintenance, healthcare, and services. And a common thread that links many of these occupational groups is the physically demanding nature of these jobs and the associated higher risks of injury and pain experienced by workers in these groups. So in Canada, we've had relatively little data on how this crisis has affected the working population. So here in Ontario, the data that we have has been limited to what's been collected during coroner investigations. So some of the most recent data come from 2019 to 2020. And here what they found is that about 13 to 16% of those who died were known to be employed at the time of death. It's not a trivial proportion, but it's also important to note that among all of the opioid-related deaths investigated by the coroner, about a third had an unknown employment status, for which we have no information on history of employment or occupation. And then when we look at that group of about that 13 to 16% that were known to be employed at the time of death, what we see is that most were employed in the construction industry. So about a third, that's that top line there. But again, it's important to highlight the data gaps here. So even among those for whom we know were employed when they died, about 16% were missing occupation information. So the data, at least from the US and a little bit here, have begun to demonstrate that certain occupational groups are at higher risk of opioid-related harms. But the question is, why are we seeing these patterns? And are there aspects of the workplace that may be contributing? And so as I already mentioned, there's that sort of common thread across those occupational groups in terms of their physically demanding nature. And so work-related injuries are one of the primary hypothesized pathways linking work to opioid-related harms. So there's many reasons why having an injury can lead to opioid use, chronic use, and potential harms. So we know that work injuries frequently result in pain and functional interference that can make it more likely that workers will use opioids to try to alleviate those symptoms. And that pain can persist. So in a recent study that we conducted here in Ontario, about 70% of injured workers reported experiencing pain 18 months post-injury, with 1 in 4 workers reporting severe pain intensity with substantial functional impairment. Furthermore, following a work-related injury, workers may face a number of different challenges that make them more likely to use opioids to manage the pain of their injuries and potentially make them more vulnerable to experiencing opioid-related harms. So poor mental health can often occur after a work injury. And then we think about the potential challenges of returning to or staying at work, which can make it more likely that workers will use opioids. So this can include pressures to return to work after injury, a lack of appropriate workplace accommodations, insufficient sick leave and job precarity, as well as interruptions in employment that can exacerbate poor mental health. Add this all to the fact that oftentimes pain relief options are limited and can be quite costly. And so workers may find themselves in a situation where they no longer have access to workers' compensation benefits to be able to pay for these non-pharmaceutical options. Now, there's some research demonstrating that there are similar occupational patterns in opioid prescribing. So that is, workers in occupations with these higher rates of injury are also more likely to be prescribed opioids for pain. There's also a large body of research that has demonstrated specifically that opioid prescribing, including long-term use and early use, to be common after work-related injuries. Although most of these studies come from the US and are fairly outdated, so we don't have much in the way of recent data to understand the extent to which this is still happening, particularly in a Canadian context. But given all of this, I guess the question is there actual research that links workplace injuries to opioid-related harms? And so there is an emerging body of literature, again, from the US, that suggests that there may be a role for work-related injuries as a risk factor for opioid harms. So in one study, 57% of those who died of an opioid poisoning had a lifetime history of work injury. In another study, injured workers with low back pain workers' compensation claims had a 62% increase in risk of dying from a poisoning compared to the general population, and a longer time off work among these injured workers was also associated with an increased risk of death. And finally, in this last study, injured workers had a 79% increased risk of being diagnosed with opioid abuse, dependence, adverse effects, or poisoning compared to non-injured workers within the first 36 months of their injury. So beyond the role for workplace injuries, again, that's the primary hypothesized pathway, but there are potential other reasons from a workplace perspective, at least, for why certain occupational groups may be at higher risk. So I'm just going to quickly touch upon some of those. So when we think about those occupational groups that we've seen in some of that US data, they typically are male dominated. And what that can mean is that there are certain gendered norms in the workplace about showing strength, about working through pain, being tough, which could be a contributing factor. Some industries and workplaces may also be more normative when it comes to substance use in their workplace, or substances may be even more accessible. And there may be other aspects of the work environment that could be contributing. So this can include things like the psychological and time demands of these jobs, how much control workers feel that they have over their work, how isolating the work is, and the nature of the employment arrangement, such as non-standard work arrangements. And finally, concerns about disclosure may also play a role. So workers may not be forthcoming about either their pain or their substance use due to concerns about stigma or about the consequences that they may face at work if they do disclose that information. And so this could potentially exacerbate issues that the worker is facing. There is limited research evidence at the moment, though, to support these hypothesized factors just yet. So our project team has tried to fill some of the knowledge gaps as a very starting point on this issue here in Ontario, trying to generate some of the first evidence from a Canadian perspective. So the overall project objective was to monitor opioid-related harms in the Ontario workforce by adapting an existing resource known as the Occupational Disease Surveillance System. So the goals for today's presentation will be to present some of the findings from our analyses. In the first set of our analyses, what we've done is we've compared rates of opioid-related harms among a group of injured workers in the Occupational Disease Surveillance System to the rates of opioid-related harms among those in the general Ontario population to see if there's a difference. And in the second, we've been examining whether there are occupational patterns in opioid-related harms among these injured workers, similar to some of the data from the US. So I'm just going to now send it over to Jeavana. She's going to take you briefly through the methods and the results.
Thanks, Nancy. So at the OCRC, the Occupational Cancer Research Center, we established a unique system known as the Occupational Disease Surveillance System, which we often call the ODSS, which was essentially developed to identify and monitor work-related disease in Ontario. So it was created in 2016 by linking existing provincial health databases with job information so that we could study occupational diseases and inform prevention activities. So essentially, we're focused on identifying at-risk workers, the potential hazardous exposures within the workforce, and some of these new sort of outcomes of interest like opioid-related harms. So we've been successful in identifying many cancers and other non-malignant diseases among workers, and we have about 2.3 million Ontario workers in this cohort. So for this project, we're going to be looking at occupational data among about a 1.7 million Ontario workers from the ODSS. And workers are identified first in the Workplace Safety and Insurance Board, or WSIB, accepted lost time compensation claims records between 1983 and 2019. And this is where we get their job information. So the WSIB file contains information on the accepted lost time claim for their work-related injury or illness. And this includes their claim or accident date, their name, sex, birth date, death date if applicable, their nature of claim or injury, and the occupation and industry at the time of the claim. So this is where we identify the worker's employment information through their reported occupation or industry. And we're interested in looking at the occupation and industry at different levels that are available. And so in the WSIB records, we can look at occupation and industry at 3 distinct levels, which we often call the division, major, and minor level, where major is our broadest category of their job title, and then minor is our most specific job title. So these workers are then linked to the registered persons database, or known as the RPDB, which gives us information on if an individual died or emigrated out of the province, but it also gives us their residential information. And the RPDB also includes all Ontarians who are registered for provincial health insurance. So each person is assigned a unique health insurance number. And then we use this health insurance number to link the workers to their hospital records. So for example, hospitalizations or the discharge abstract database and the National Ambulatory Care Reporting System, which gives us information on emergency department visits. And we have this information from 2006 to 2020 for this project. And so we follow these workers from their WSIB compensation claim and identify if they interacted with the healthcare system through their hospital records. And also, this is, we're interested in the working age group, and so we do cap it at the age of 65. And the end of follow-up would have been 2020. At that time period, that was the end of reporting that we had available. So through the hospital records, we're able to identify opioid-related harms. And this is, again, the hospitalization and emergency departments visits between 2006 and 2020. And so the first opioid-related harm that we were able to identify are opioid-related poisonings, which many refer to as overdoses. And a poisoning can occur when an opioid is taken incorrectly and results in harm. And poisonings can be differentiated by intent. So we can identify if it's accidental, intentional, or of unknown intent. And the poisonings can involve pharmaceutical or non-pharmaceutical opioids or a combination of both. The second opioid-related harm of interest that we were able to identify for this project are mental and behavioral disorders. And this includes a wide variety of mental and behavioral disorders that can differ in severity or clinical form. So some examples are withdrawal or intoxication, but they're all attributable to the use of opioids and may or may not have been medically prescribed. So overall, you can see at the bottom there in our two boxes, we're able to identify about 10,000 cases of poisonings and 11,700 cases of mental and behavioral cases among for mental and behavioral disorders. And so we're giving you the number of events and then also just the number of cases. So individuals could have had multiple events in our ODSS. So for the first analysis we're sharing, we wanted to compare the rates of opioid-related harms among the ODSS workers, and so these are the workers with accepted lost time compensation claims, to those of working age in the general Ontario population. So again, if we use the ODSS or the working cohort to identify the number of cases of opioid-related harms, and then we looked at the general Ontario population, and that data was obtained through the Institute for Clinical Evaluative Sciences, known as ICES in Ontario, and this was to identify incidence rates of each opioid-related harm in the province so that we could compare our sort of internal group to the external population. So when we compared to our working cohort or the ODSS, when we compared them to the general Ontario population, we saw higher risks of opioid-related harms among this group of workers. And so we use the SIR, the standardized incidence ratio, as an estimate, as a risk estimate to identify if an SIR is greater than 1, then that means that their opioid-related harm is elevated among the ODSS workers compared to the general Ontario population. So we can see here that if we look at the overall risk by type of opioid-related harm, so whether it be poisonings or mental and behavioral disorders, the SIRs are above 1. And when we look at the data source, so emergency department visits or hospitalizations, we can see again that the SIRs are greater than 1. So this gives us an idea of how our worker cohort compares to the general population and confirms that we're seeing a higher risk among this group of workers compared to the general population. And it also identifies different ways that we can slice our data set. So on the next slide, you'll see that we're now showing you the top occupational groups with the highest risks based on emergency department visits for opioid-related poisonings. And here we're showing you division level occupational groups. And so these are sort of the broadest groupings that we have available in our data set. And what we're ultimately showing you is that results here are consistent with findings from previous studies that identified occupational patterns in opioid related death in comparison to the general working population. So similar to what we're showing you on the slide, we know that the opioid death data, primarily from the United States that Nancy touched upon, have found a variety of jobs characterized by high levels of physical labor to be at a higher risk compared to occupations that are not considered manual labor work. So here we can see construction and trades, material handling, processing, machining, forestry and logging, and transport equipment operating are all at elevated risks compared to the general population. For construction and trades, findings are driven by those working in specific groups. So again, we can narrow down their division level into major and minor level, which would give us more specific job titles within the construction and trades group. And we can see that the heightened risks are primarily among excavating, grading, and paving, and other construction trades such as roofing and painting, and brick and stone masons. We saw that materials handling was driven by those employed as freight handlers or other material work, or longshore men and women. We saw that workers in metal processing have a higher risk as well among the processing group that encompasses mineral, metal, and chemical workers. And we can see here that for machining, the findings were driven by those in machine tool setting up and operating, metal shaping and forming, sheet metal workers, welding and boiler making, wood sawing and wood machining. So there's a number of jobs that we can identify within these groups that are really driving those heightened risks. Within forestry and logging, which tends to be a smaller group in Ontario within our data set, findings were driven primarily by those in timber cutting. And then for transport equipment operating, this was primarily driven by workers in railway transportation, bus and taxi driving, truck driving, among others. There were a number of groups that were driving these heightened risks. So on the next slide, I'm going to just show you again sort of how we're seeing consistent results for opioid-related poisonings based on hospitalizations. So even if we're slicing the data, looking at different data sources like emergency department versus hospitalizations, we still see quite consistent findings. And here you can see again the occupations within these 6 division levels were again at a heightened risk compared to other groups. And the difference here compared to the emergency department visits is that we're seeing service occupations elevated for hospitalizations related to opioid-related poisonings. And within service occupations, we saw that the elevated risks were primarily among chefs and cooks, bartenders and waitresses, and managers and supervisors within the lodging and accommodation occupations, and then also cleaning occupations related to janitor or cleaning staff, among others. So in some cases, we can identify all of the groups that are elevated. There may be miscellaneous groups within these sort of broader groupings like service occupations, but we do think it's still important to highlight that these were the top 6 groups. And on the next slide, here we're just showing you the overall results, again, by occupation at the highest level or division level, shown separately for emergency department visits and hospitalizations for mental and behavioral disorders. So the previous 2 slides showed you the results for poisonings, but now we're showing you the other opioid-related harm that we were able to examine in our cohort. And so you can see the overall risk, and you can see the bar at 1 and the overall risk at the bottom is greater than 1 for the entire group. But we can see a number of specific occupational groups that are elevated beyond that overall risk. So some of these consistent findings, again, are among those in construction and trades, materials handling, processing, and machining, among other groups. We also saw some consistent decreased risks, which are also important to note, such as those in teaching and related. So we often try to make sure that we're, transparent about all the results we're seeing, and you can see that from the highest risk groups to the lowest risk groups, what we're seeing in the overall data set. So that analysis was comparing our worker cohort to the general Ontario population. The second analysis, which I think is more important, is where we're going to show you the occupational patterns among opioid-related harms within our ODSS again, but compared to other workers in the ODSS. So now we're going to do an internal comparison where, for example, we would compare construction workers in our cohort and compare them to all other workers within the same cohort, and rather than the general population. And this will give us more of a comparable group where everyone in the cohort has an accepted claims record with WSIB. So again, this is just to show you the example where we're comparing internally workers in specific groups to other workers in our cohort. So here we're presenting the top occupational groups at the broadest level or division level again, that had higher risks of both poisonings and mental and behavioral disorders. And so we combined it on this slide so you can see that there is an elevated risk for both among the same occupational groups. And again, the risk estimate that you see here, we know that if it's greater than 1, then these risks are higher among these specific groups, and these are all statistically significant. And so workers in construction and trades, again, are at the top of our list among forestry and logging, materials handling, processing, machining again. And given the larger number of workers we've got in this cohort, as we mentioned, about 1.7 million, we're able to dig down and look at these groups in much more detail, at least at the major and minor level, to identify what specific job titles are driving the risks that we see here. And before I get into more of the details of specific groups, on the next slide, I just wanted to show you the certain division level groups that are elevated for only one of the harms or one of the 2 harms. So thanks, Nancy. So workers, for example, in mining and quarrying, we saw had a statistically significant elevated risk for mental and behavioral disorders, but not for poisonings. Whereas transport equipment operating, had a significant risk for poisonings and just an elevated risk for mental and behavioral disorders. And the reason we want to pinpoint some of this is really to show that there are differences in the risk estimates and that we can sort of dig a little bit deeper to identify groups that might have an elevated risk of one harm or an elevated risk of both harms. And I think that's important to point out through our analyses. So on the next slide here, you'll see that we can dig deeper, as I mentioned, into specific groups. So for example, we saw consistent findings across construction and trades. And this analysis again compares this group of workers to all other workers in the worker cohort. But we can also identify which groups are driving the elevated risks in construction and trades. And we can see that this is primarily among the excavating, grading, paving, and related construction workers and the other construction trades, which again are those such as roofers and carpenters. And you can see that the risk estimate is over 1 and statistically significant. But we also are able to look at groups that have a decreased or lower risk of an opioid-related harm or no association. And so we can see here that those in electrical power, lighting, and wire communications have a lower risk of opioid-related harms. And previously, Nancy and I have presented to these specific groups, and they do reflect that they see that as well in those specific occupational groups within construction and trades. So overall, our study has the unique ability to dig down into these occupational groups and identify sort of which direction the risk estimates are going, whether it be increased, decreased, or seeing no association. So similarly, again, we're showing you sort of the major level groups within machining. So you can see at the bottom, they're listed there, metal machining, metal shaping and forming, wood machining, and other machining and related. And again, these are the groups that make up our machining group. But we can see that the findings seem to be primarily driven by occupations in metal shaping and forming, which includes our welders, our boilermakers, our sheet metal workers. And we can see that at this major level, the metal machining occupations, which include tool and die and machine setting up occupations, are actually demonstrating a decreased or reduced risk. And so this is important for us to be able to pinpoint, for example, if we're targeting prevention activities, where they would be targeted and which are the occupational groups that are driving sort of these risk estimates. Again, when we drill down a little further among transport equipment operating, which often tends to be a group of interest, we see that risks are elevated among water transport and motor transport occupations, but we see a reduced risk among air transport occupations. And we don't see anything for the railway and other transport occupations. So a lower risk among the air transport may be attributable to provincial policies and enforcement around substance use among air transport workers. And I think that this is important given that in transportation, there seems to be a much more interest in sort of where these risk estimates lie and sort of which groups are driving these heightened risks. So on the next slide here, as we shared sort of the groups that have elevated risks or some of the lower risk groups, we also wanted to share groups that remained sort of where when we looked at these at a high level, so the division level, we didn't actually see an association. So there on the left-hand side, you can see medicine and health, service, sales and clerical. And again, this is for our internal analysis. So comparing those specific groups of workers to other workers in our cohort, we didn't actually see an association. But when we dig deeper into our major and minor level groups or the specific job titles, this is where we do actually see an association. So some of these interesting groups like medicine and health, we tend to see an elevated risk for harms and other outcomes among nursing aides and orderlies. And again, service occupations, which is really, as I mentioned, a mixed bag of occupations where we saw an elevated risk compared to the general population. But digging down into our internal comparison group, we can see that these were driven by some of the same groups that we saw with that sort of external comparison. So here, security guards, janitors, food preparation workers, lodging and other accommodation workers, apparel and furnishing service, and personal services, which includes hairdressers and barbers. We also see an elevated risk among specific sales and clerical workers. And I just wanted to add that even though we see it for security guards, we did not see it for other protective services, such as police and firefighters, which is often a common group of interest in our ODSS analyses. And this is just to highlight that it is important for us to be able to have intricate data so that we can really figure out, which groups are driving these heightened risks, but also which groups where we don't see an increased risk or we see a reduced risk or no association for. And so I'm going to stop there with the results and pass it back to Nancy. I know it's a lot to digest, so we're also happy to take questions at the end about these specific results.
Thanks, Jeavana. So as Jeavana just said, she took you through quite a few findings. And so I'm just going to briefly summarize, I guess, the implications of those results. So if you recall, the group of workers that we're examining in this study in the ODSS all had an accepted lost time workers' compensation claim for a work-related injury or illness. And so when we compared this group of workers to the general Ontario population, we found that the rates of our two key opioid-related harms, so poisonings and mental and behavioral disorders, were significantly higher among these injured workers. And so this starts to add to what the growing body of literature is suggesting, that work-related injuries are a risk factor for opioid-related harms. Although, one caveat here, given the nature of the data that we had, we couldn't disentangle how much of that risk would be due to injury versus other factors, which I had already sort of described earlier in the presentation. What we also found is that certain occupational groups demonstrated higher risks of opioid-related harms. And again, this was particularly true for occupations that we traditionally consider physically demanding. Our results are consistent with several studies in the US, and it does provide an important signal for which subgroups of the workforce, particularly among these injured workers, where prevention and harm reduction activities can be targeted to reduce those harms. So I know we've given you a lot of information in a short amount of time, so we wanted to share where you could go to sort of find out more and maybe digest it in a little bit more time that you might have. So we do have a project website, the URL here, opioidsandwork.ca. And on this website, there are links to our open access academic publications. So you can actually find it under I'm not sure if my cursor is working here, but under project findings. And then to accompany those publications, because some of it can be very dense to read, we've also produced a series of infographics and lay summaries. So to hopefully sort of zero in on the key messages. We've also developed a data visualization tool for use by members of the public. Again, there's a heading at the top of that website there you could see called Data Tool. And essentially, this tool can be used. Again, it's based on injured workers here in Ontario, but it does give some flavor for Canada, at least some Canadian data here. Where here you can create graphs of depicting opioid-related hospitalizations and emergency department visits that occurred among these injured workers from 2006 to 2022. And in this tool, we have three dashboards, one for each opioid-related harm. We've talked about poisonings and mental and behavioral disorders today, but we did have a third that we were looking at called adverse reactions. And essentially, it's a little bit different from what we've presented today, but it's when an individual takes an opioid as prescribed, and it results in some sort of adverse effect or reaction. So it's a little bit different, but we do have a dashboard there as well. And each of these dashboards can be customized according to year. So you can look at trends over time, age and sex, the region in Ontario, as well as occupation and industry at the time of injury. And finally, last year, we organized a workshop with over 100 attendees to share some of this research evidence from ourselves, but also from the US. We heard workers' stories of lived experience at this workshop, and we also heard from various organizations about the strategies that they've implemented to address opioid-related harms. We also had a brainstorming session among attendees where they discussed they sort of brainstormed what actions needed to be prioritized to address this issue in workplaces. And these included actions that were aimed at primary prevention of opioid use and harm. So that includes the prevention of work injury, but also different things around the system level, primary prevention activities, and clinical level. So improving prescribing as an example. They also identified recommendations for workplace strategies for helping workers struggling with substance use, and the need for more evidence to support these actions. So I wasn't sure if we'd have enough time to really discuss this, but we do have a report that summarizes that workshop, and it can be found on our project website. The URL is here. It describes all of these sorts of things in detail, and it also includes some cross-cutting actions that support these priority actions. So things like the need to address stigma. Stigma is a potential barrier to improving things in workplaces. And anyway, so I would encourage you to go and read the report and all of the great ideas that were put forth by attendees. So I think with that, we just want to say thank you again for the invitation to present today, and we're happy to take any questions that you might have.